Day retreat Friday. It was my first time in a North Campus building and my first time to hear about the progress that's been made in all of the groups seeking to improve UT Southwestern's ability to translate research to practice. Another exciting event was that Mujib Bassett spoke in the Making Digital Health Real seminar run by my previous Centre for Digital Transformation of Health at the University of Melbourne. There were almost 100 people from Australia online for his talk. Similar to the goal of the CTSA, the theme of his talk was how to work at the intersection of the university and the health system. The relationship at that intersection is a key ingredient to advancing learning health system, according to this paper by Peter Steele on learning health systems in the age of AI. On the left of this diagram, the authors emphasize that synergy between biomedical informatics and health IT groups is needed to create curated, interoperable data. On the right side, a collaboratory of researchers, clinicians, and health systems leadership are required to develop, implement, and evaluate data-driven interventions. So how do we create effective partnerships between researchers and the health system? Have you heard or uttered any of these complaints? I know I have. I've heard more than one health system executive note that research is too far removed from real problems to be useful. Researchers often pass up opportunities to have real impact in the health system because the problem, although important, isn't methodologically interesting. These comments are valid barriers to bridging the research practice divide because they indicate misaligned incentives. In his talk, Mujib gave advice to the researchers in the audience. Work on problems the health system needs, even if they're simple, because if you align your interests with theirs, the opportunities to scale to harder problems can arise. He said that trust is the keystone to the relationship and it's hard to build and maintain. Also, trust in researchers knocking on the door of the health system is a hard-earned privilege and not a right. In my talk at the CTSA retreat, I shared 3 guiding principles that I've learned. To those of us who develop methodologies and technology, we're often hammers looking for a nail. The reason most digital tools are not implemented in real settings isn't that the technology isn't advanced enough. We have a lot of hammers, over 300,000 health apps that are seldom used and 10,000 publications a year on AI. It's that we haven't figured out how to solve problems together. To the health system, we need research to improve the system. There's so much we still don't know about how to provide the best care, even for those conditions with evidence-based guidelines to follow. Braithwaite showed that for these conditions, only 60% of the care you receive is evidence-based, 30% is waste, and 10% causes you harm. Think about the positive effect quality improvements had in healthcare, but it's not enough. Current top-down or chain logic strategies based essentially on linear models of change and relying on policies, hierarchies, and standardization have proven insufficient. Instead, we need to marry ideas drawn from complexity science and continuous improvement with proposals for creating a deep learning health system. Leandro Herrero on LinkedIn called for system-wide frameworks over and above the small projects. He said large-scale change is not small-scale change repeated many times. We need to think and act as a system. When I became the chair at the University of Utah, it was my goal to help the Biomedical Informatics Department return to its roots and start working more closely with the health system. So I launched a seed funding program for researchers working with an operational partner. I even sat with the CEO of the hospital and had him sort cards about the projects he most cared about. 13 projects were funded. What do you think the return on investment was? Papers published, a few. Grant proposals stemming from the collaboration, 0. Implemented projects, 0. Why? Because the successful partnership between research and operations requires more than just a person on each side of the fence with great ideas. It requires system-level frameworks and infrastructure to support the partnership. Our next attempt was much more successful. Reimagine EHR is led by Ken, who has a team funded by the health system to work on innovative solutions, and Guilherme Del Fiol, who's a master of aligning operational projects to research grant ideas and getting them funded. And the Smart on Fire apps that they developed to implement in the EHR are selected by a cross-sectional governance group. What's the return on investment for Reimagine EHR? Over 25 complex Smart on Fire apps implemented in the health system and in other health systems in the U.S., many papers, and over $50 million in grants affiliated with the projects. I take from this the guiding principle that we need to design the relational conditions that enable disciplined experimentation with many solutions, then phase out those that don't work and scale those that do. I'm working on a learning health system vision and plan for my role as Chief Learning Health Officer, and I'm thinking a lot about the ingredients we need in that framework, in that system. Here are some categories that I think will be important. Governance and management to select projects and align incentives. A portfolio of LHS projects that enhance existing initiatives like quality projects and surface new ideas. Culture and capability so that more stakeholders are involved in generating and working on learning health system projects. Socio-technical infrastructure to make it easier to learn from data, develop and implement promising solutions, and determine what's working and what needs to change. And a research program to help define what makes operationalizing a learning health system work. In terms of infrastructure, we're designing what I'm currently calling the AIMS Studio, a digital and physical space to more quickly co-design data-driven solutions that we can feasibly implement at UT Southwestern and potentially port to other places as well. I just launched a working group to flesh out this plan, and I'll keep you updated. Have you heard the term "let sleeping dogs lie"? Well, there were a lot of sleeping and dreaming dogs at our house last week.